there will be a Q&A at the end of the session. And if you have any questions, please type in the chat box, and at the end of the meeting, the presenters would answer the questions. And also there'll be a link that will be put on the chat box to share your views about how the presentation went, so that it would help us do better for next year. So right now I'll be welcoming Befi for... Yes, please.
Thanks.
So right now I'll be welcoming Befi for the welcome address. Over to you, Befi.
Thank you. To introduce our first speaker for the day, Dr. Gani is a consultant hematologist working in Lebu. He also works at the Ghana Institute of Clinical Genetics, what we call here as the Sickle Cell Clinic. He's a fellow of the Ghana College of Physicians and Surgeons, and as I mentioned, has specialized as a consultant hematologist. He is well versed in clinical research, participating in a number of research work in sickle cell disease and other hematological conditions. Dr. Gani is also actively involved in national policy and has served on the Hydroxyurea Reimbursement Expert Committee, and previously as the General Secretary of the Ghana Society of Hematologists. His commitment to advancing care for sickle cell and other hematological conditions is undoubted, and we are privileged to have him speak to us. So audience, please let's welcome Dr. Gani. Dr. Gani, your audience.
So thank you very much for the introduction. Sharing my screen. Please, can we all see my screen?
Yes, please.
Yes, Dr. Gani.
All right, so thank you very much for the opportunity to give this presentation at this GP's Day 2 Masterclass. So the topic I was given was sickle cell disease, what a primary care physician should know. So this disclaimer slide here, and this is going to be the outline of today's presentation. I'll start with a little background in sickle cell disease. I'm sure this is a slide that most of us are familiar, a cartogram that most of us are familiar with, and it's indicating that annually we have over 300,000 deaths, children born with sickle cell disease, and approximately 80% are born in sub-Saharan Africa. It tells you that we have a very high disease burden in our region. And in Ghana, the annual birth rate has been consistently around 2%. So in sickle cell disease, usually there's a mutation in the gene that codes for the beta globin chain. You know, the hemoglobin has 4 chains, 2 pairs, 2 alpha chains, 2 beta chains. And when there's no issue with the hemoglobins, you have the formation of the adult hemoglobin. But in adult hemoglobin A, in sickle cell disease, there's a mutation in the beta globin gene, and instead of producing a hemoglobin A, you produce a hemoglobin S. Now, what's characteristic about hemoglobin S is that when there's deoxygenation, it polymerizes within the red blood cells, and this distorts the shape of the red blood cell. So, you know, at the in the lungs, the red cells are oxygenated, and when they get to the tissues, they offload the oxygen, so they become deoxygenated. But with a normal adult hemoglobin A, whether in a state of being oxygenated or not, the hemoglobins are still fluid within the cytoplasm of the red cell. But in sickle cell disease, when there's deoxygenation, hemoglobin S polymerizes, and this changes the shape of the red cells. And I've spoken about the fact that you can have a mutation that can result in hemoglobin S. Now we have other mutations too as well, and that can give you other abnormal hemoglobins. So in sickle cell disease, when a person inherits a hemoglobin S together with another abnormal hemoglobin, that's what uh,
Oh, sorry for the technical glitch. I'm sure he will be back. He would log in again. Sorry about that, please. Dr. Gani, if you would have to reshare, because your slides are not, we can't see your slides anymore. Hi, Michael. Please, can you get in touch with Dr. Gani? Let's know why. I think he's having some technical glitches. Please just let me know.
Yeah.
Thank you.
So
Oh, okay,
that is
he's joining right back. Thank you.
I think it's on now.
please
So
can you hear me?
you kindly share your screen again. Yes, please, you can hear you.
All right. Thank you. Yeah, so this is where I got to, and I was explaining that because of the sickling of the red cells and the fact that the red cells become damaged, the membrane of the red cells become um, distorted, and therefore it becomes inflexible. It leads to hemolysis within the vasculature. Also, because of the abnormal shape of the red cells, the spleen considers these cells as aged and then takes them out of circulation. And therefore, they are destroyed way before that lifespan of 120 days. So in sickle cell disease, the lifespan of the red cells is reduced from 120 to less than 20 days, and that's very significant. So they're just chronic hemolytic state, and therefore they have this state of anemia. Um, the hemolysis also will result in an inflammatory response because of the release of free hemoglobin into the circulation, which can damage the endothelial cells. And the inflammatory response causes a lot of white cells to be released into that portion or that area where the inflammation is taking place. And they come with a lot of increase in a lot of adhesive molecules. And therefore, they attach themselves to that portion of the endothelium. They block the endothelium, and that results in vaso-occlusion. Not just the white cells alone, but the platelets are involved, and also very immature red cells the reticulocytes, which also have a lot of adhesive molecules on their surfaces. On top of that, you have your sickle cells, which are inflexible and are not able to bend in tiny vessels, so they add up to this insult. So you have hemolysis and vessel occlusion playing very important roles in the pathophysiology of sickle cell disease. So when you meet a sickle cell patient, what you must realize is that there's this clinically silent vaso-occlusion that is going on all the time. And there's this chronic state of hemolysis that is going on all the time. And there's this chronic inflammatory state that is also ongoing. Now, so these are the subclinical level. So these ongoing vaso-occlusions can accumulate in what we call vaso-occlusive crisis. And that is that's the clinical hallmark of the disease. Now, most of these vaso-occlusive crises are unpredictable, and they're also painful events that can lead to medical intervention. That means that the patient ends up coming to the facility and needs to be attended to. VOCs are associated with a decreased patient quality of life and also increased risk of organ damage and mortality as well. So because of the silent vaso-occlusions, you can imagine that maybe someone's kidneys and there are silent vaso-occlusions going on in it all the time. These are not clinically apparent, but then it gets to a point where after repetitive vaso-occlusions, it results in a renal disease, and that's when you're actually seeing diagnosing the person with a problem with the kidneys. So we should bear in mind that when you meet a sickle cell disease patient, they have this vaso-occlusion that is going on all the time. It is silent. They also have a chronic hemolytic state, and they also have this chronic inflammatory state that is ongoing. So I want to look at the complications of sickle cell disease. The complications are either acute or chronic. And so from the pathophysiology, you notice that sickle cell disease affects almost every organ of the body, but pain is the most common acute complication. And then when a patient ages, the chronic complications produce organ dysfunction. And then highly vascular organs are particularly susceptible to vaso-occlusive related complications. So organs such as the lungs, the kidneys, and then the spleen. So if you look at the diagram on your right, this young gentleman, you can see that almost every aspect of the body is involved. So the acute complications are in green, and then the chronic complications are in blue. So what look at the clinical hallmark of the disease, which is pain. What is the commonest vaso-occlusive complication that an individual presents with? What most of us are accustomed with is acute pain, but we also want to draw our attention to the fact that in sickle cell disease, there is chronic pain. So with acute pain, there's sudden onset of localized or migratory pain that is continuous and throbbing. Now, it is the hallmark of the disease and the most common cause of hospitalization, and that will require emergency treatment in the emergency room. And this is caused by vaso-occlusion by sickled red cells. When there's occlusion of that portion, there's tissue ischemia, which results in an inflammatory response, and then there's nociception, which the body interprets as pain. Most pain is managed at home, and the more severe ones are presented to the hospital. That's when we get to see the patients. So, one of the important things is that when you meet a sickle cell patient, you have to take a very good history of the person's painful episodes, because they might have had several painful episodes that they manage themselves at home. Now, in contrast with chronic pain, it's very complex, and it's a pathological pain that presents on most days, lasting over 6 months, and usually as a result of nervous system sensitization. So in chronic pain, you have abnormalities in your peripheral nerves, the brain, the spinal cord, and these transmit pain signals with the body, with the person feels. Now, it is important to note that chronic pain has a big toll on the person's psychosocial well-being. So it is related a lot to depression, anxiety, feelings of despair, insomnia, loneliness, helplessness. People can even develop post-traumatic stress disorder and dependence on pain medications. It can start during childhood, but its prevalence increases with increasing age. Most chronic pain is managed at home. You would usually not um, admit someone to the facility with chronic pain. I mean, it could happen, but that's not the usual thing. And so they will come complain of this chronic pain, and you give them pain medication. So most chronic pain is managed at home. So when it comes to dealing with acute and chronic pain, the goals are a bit different. With acute pain, which is as a result of vaso-occlusion and inflammation, the goal is to heal the immediate process. You want to target what is causing the pain at that instant. But with chronic pain, that is as a result of nervous system sensitization, you want to restore function and improve the quality of life of the individual. So this is a simple algorithm when it comes to the initial management of acute pain. So when a patient comes to you, you want to take history and examine the patient. You want to find out whether there are other signs of other complications. For instance, does the person have sepsis? Does the person have any pulmonary symptoms, any abdominal or orthopedic events? If it's just pain and there are no any other underlying signs or complications, you want to find out whether that pain can be managed in the clinic, that's the day hospital, or the person can receive a short-term stay at the facility. If it is a yes, then you go ahead and treat the patient in the clinic, or you are transferred to the alternate setting, which has been made available in your facility. But when a patient comes to you and has signs of other complications, you would want to refer the patient to the emergency department. Now, even without other signs of complications, after assessing the pain, if you think the patient cannot be managed at the day hospital or the day clinic, or needs much more care, then you refer the patient to the emergency department, where they will triage and they evaluate the complications, and then they will begin an analgesic management within 30 minutes of triage or 60 minutes of administration. So it is important that when a patient comes with pain to the facility, our approach to it should be aggressive and very prompt, because, like we mentioned earlier, most acute pain, most pain is managed at home, and it's a very severe ones that the individual brings to the facility. So when you see the individual at the facility with pain, it's most likely that that pain is severe. So we should be very prompt and aggressive when it comes to pain management in individuals with sickle cell disease. So per the protocols that are available, you can administer opioids, and then you have to really assess the pain every 15 to 30 minutes, and you have to re-administer medication until there's pain relief. Right? And there are other non-pharmacologic approaches that we can also institute when it comes to pain management. Now, at the day clinic, you can manage the pain for about 6 to 8 hours. If the pain has not resolved, then that means that the person will require admission to the ward. Now, when it comes to managing pain, VOCs, one of the common complications which accompany VOCs is acute chest syndrome. The patient might not have come with pulmonary symptoms, might not have come with a chest pain, difficulty in breathing, reduced saturation, might not have come with a fever or any of such pulmonary symptoms. But we must be mindful that even when the patient has come with just pain, maybe involving the lower limbs, acute chest syndrome over the period has been seen to be a common complication which accompanies VOCs. So, whilst we are managing the pain, one of the things we institute is prophylaxis against acute chest syndrome. So a patient will come with pain, saturations are fine, entry is adequate, breath sounds are normal, but we still want to institute incentive spirometry for that patient. That's a means of chest physiotherapy, so that we can prevent clinical deterioration and also prevent and reduce the incidence of acute chest syndrome in individuals who present with a hospital with just acute painful episodes. So I'm sure we've seen this. This is our one Baker faces pain rating scale, which is used to rate pain in individuals with sickle cell disease. So the pain is rated from 0 to 10, and you that's the numerical pain rating scale, and you ask the patient assessment, and the patient is going to tell you whether it's 4, whether it's 7, or whether they think it's 10. Another way of cross-checking is to look at the facial expressions of the individual. Now, sometimes some of the patients are used to a lot of pain, so their facial expressions may not really indicate the severity of the pain that they have. So it's always good to go with the numerical scale as the patient tells you. Now, when it comes to some of the non-pharmacological and lifestyle changes that are required in order to manage pain and also or to avoid painful episodes, hydration, as we tell our patients, is recommended. They have drinking orally a lot. When it comes to the facility in pain, to one of our goals of management is to hydrate them as well. Patients are counseled to avoid low oxygen environments. They are counseled to limit exposure to extremes of temperatures, whether cold temperatures or whether very hot temperatures. These are all for acute and chronic pain. When it comes to chronic pain, there are coping strategies that the patients might be taught. Examples like deep tissue massage, muscle relaxation therapies, acupuncture, and then self hypnosis. Now, this is the WHO pain ladder that is used in terms of selecting analgesia for the individual who has come to the facility with pain. So, from the pain scale, you can have mild pain, mild to moderate pain, or moderate to severe pain. So based on the assessment, you choose the particular grade of analgesia for the patient. Now, opioids and not opioids are used by patients to treat mild or moderate pain at home. And for more severe pain, when they come to the facility, we usually give them more potent opioids. It is important to understand that when it comes to pain management, analgesia do not prevent or stop progression of a vaso-occlusive crisis, but they can help to manage pain based on the patient-reported severity, right? And then analgesia do not necessarily prevent long-term tissue damage. So you're helping with the pain, all right, but you're not tackling the the source of the pain, really. So it's something that we need to bear in mind. And we always have to choose analgesia based on the patient-reported severity. Sometimes we are concerned about patients getting addicted or dependent on medications. But from the guidelines, pain is what the patient reports it to be. Of course, there are different ways that you can assess the patients for um, dependence to medications. But once the patient reports pain and reports the severity, you choose the analgesia according to the severity that has been reported. And like we said, when it comes to pain management, it must be rapid and it must be aggressive. It must be prompt and it must be aggressive. There are situations where patients come to the facilities and it takes a very long time before pain management is initiated. That shouldn't be the case. Remember, we said even acute chest syndrome can be a complication of an acute vaso-occlusive painful episode. So if we don't treat that pain early, it will result in other complications which could have been avoided if the pain was tackled promptly. So pain should be tackled promptly and aggressively. When it comes to pain management in sub-Saharan Africa, there are some few challenges in the sense that opioid analgesics are not readily available to patients in many of the health facilities. Well, at our centers, when the patients come, we usually are available because you are working in a tertiary center. But remember that if you go to rural areas, you go to very primary centers and all that, they may not have all the opioids available. And instead, centers depend on NSAIDs and non-opioid analgesics, which are not adequate in terms of management of pain, especially what the patient has brought to the facility. How do we overcome these challenges? We all probably have area which has been shown to reduce the frequency of acute painful episodes in sickle cell disease. Of course, morphine is gradually becoming more accessible today than in the past. And like we said, there are lifestyle changes in order to overcome these challenges. You ensure adequate hydration by educating the individual, and also when they come to the hospital to an admission, we ensure adequate hydration too as well. So what are other complications that come along with sickle cell disease? We have acute chest syndrome, and usually is defined as a new infiltrate on chest X-ray in association with chest pain, fever, respiratory symptoms, and or hypoxemia. Now, when it comes to acute chest syndrome, it can be caused by a pulmonary infection, it can be caused by an embolism, it can be caused by an infarct or other factors. So sometimes there's this confusion. Do we call it pneumonia an acute chest syndrome? Do we call it pulmonary embolism an acute chest syndrome? Yes, once it is in a sickle cell disease individual and the person has a pneumonia, it is an acute chest syndrome, which is being secondary to a pneumonia, or an acute chest syndrome secondary to a pulmonary embolism. Now, symptoms of ACS, like we mentioned, include chest pain, coughing, difficulty in breathing, and fever. And acute chest syndrome often occurs in combination with or shortly after episodes of VOC, as we have already stressed. So this is a very important point. That's why when a patient comes with just an acute vaso-occlusive painful episode, we want to institute prophylaxis in terms of chest physiotherapy against acute chest syndrome. And what we do is to put them on incentive spirometry and also chest physiotherapy. In addition, when a patient develops an acute chest syndrome, we are still going to go ahead and do your incentive spirometry, but this time you're going to be more aggressive. And treatment of acute chest syndrome may involve giving oxygen therapy, blood transfusions, giving antibiotics or bronchodilators, and also giving anticoagulation to the individuals. Like we mentioned, ACS is the second most common reason for hospitalization of patients with sickle cell disease, and it is the leading cause of death. So the commonest reason for hospitalization is VOCs. The second commonest is acute chest syndrome. Sickle cell disease individuals can present with acute anemia. It is common and can be potentially fatal. Now, it could, as a result of acute splenic sequestration, what we call aplastic crisis. The aplastic crisis in sickle cell disease is a pure red cell aplasia, and usually as a result of parvovirus B19 infection. You can also have a hyperhemolytic crisis, usually from infections. Now, obviously, when a person has an acute anemia, the person will present with fatigue, lightheadedness, irritability, rapid heart rate, difficulty in breathing, jaundice if there's an associated hemolysis. Okay, and severe anemia can be treated with blood transfusion. Sometimes the anemia is so severe that you need to transfuse that individual blood. So patients with sickle cell disease generally do not benefit from iron supplements, as the anemia is not the anemia is not as a result of lack of iron in the blood. But can an individual with sickle cell disease develop iron deficiency? Yes, if there has been chronic bleeds and the person has been losing blood over a long period. So yes, iron deficiency is not ruled out in individuals with sickle cell disease, but usually the anemia that they have is as a result of the ongoing chronic hemolysis. And therefore, when you give them iron supplements, you may not, they will usually not benefit from it. Splenic sequestration is also another acute complication of sickle cell disease. And in this instance, the red cells are trapped in the spleen, all right, and they remove them from the circulation and cause the spleen to enlarge. Now, the spleen as an organ in the reticular endothelial system serves as a reservoir, and about 5% of red cells are stored in the spleen. And when the spleen enlarges in instance of sequestration or when there's hypersplenism, you can have as much as 40% of the red cell mass being stored or being pulled into the spleen, and that can result in an acute anemia. So, yes, symptoms would include sudden weakness, rapid breathing, extreme abdominal pain from the stretching of the capsule of the spleen, rapid heartbeat, and pale lips and skin. Children undergoing a sequestration crisis are at risk of severe acute anemia and cardiovascular collapse. And then the management for spleen sequestration is usually conservative and would require blood transfusion, would require the person to be given oxygen if there need be. And when there's cardiovascular collapse, there's resuscitation instituted. When a
Dr.
person gets
Gani,
repetitive spleen sequestrations,
Dr. Gani, you have like 10 minutes to round up because I gave you extra time because of the glitches so that you round up. Thank you.
thank you. So when a person gets repetitive spleen sequestration episodes, you may want to consider partial splenectomy or total splenectomy in such individuals. Now, in males, you can have acute and recurrent priapism, and it's something that we must attend to promptly because it can result in erectile dysfunction. Usually, analgesia and hydration is what is instituted as the initial management, and then you can have aspiration of blood from the penile shaft. So you always have to involve the urologist. When the initial treatment fails, they would want to do further surgery. Stroke is also an acute complication of sickle cell disease. You can have ischemic stroke, or you can have hemorrhagic stroke. The transcranial Doppler is usually what is used to screen for stroke in children up to the age of 18 years. And the guidelines recommend that you can give simple or exchange blood transfusion when a person develops a stroke. But over the period, with a lot of studies done with hydroxyurea in individuals with sickle cell disease, hydroxyurea has been shown to be both a primary and a secondary preventer of stroke. Now, in sickle cell disease, they would usually, as a result of the repetitive infections in the spleen, develop hyposplenism or functional asplenia or autosplenectomy. So as a result of that, they are at risk of infections by encapsulated organisms like Streptococcus pneumoniae. And these infections are usually frequent in children and they can be fatal, can result in death or strokes. Sickle cell disease patients can have renal complications, and it's a spectrum from hyperfiltration to microhematuria to microalbuminuria to overt proteinuria, and then even developing a nephrotic syndrome as well. And because of the risk of infection, they also have risk of developing urinary tract infections and pyelonephritis. They can also develop renal infection, renal papillary necrosis that can lead to hematuria. These are cardiovascular complications that an individual with sickle cell disease can have, different thrombosis, pulmonary embolism, pulmonary hypertension, diastolic dysfunction, and cardiomyopathy. When you look at the pathophysiology of sickle cell disease, you would notice that as a result of the increase in the adhesive molecules, individuals with sickle cell disease are actually in a hypercoagulable state. So the risk of developing these thrombotic complications are increased. Retinopathy is also a complication that we should look out for in individuals with sickle cell disease. They can also have orthopedic complications, avascular necrosis, and acute osteomyelitis too, as well. And then with the complications, leg ulcers are also frequent, usually common in those with hemoglobin SS, sorry, that's those with sickle cell anemia, the severest form, and they are associated with significant morbidity and reduced quality of life. So how do we identify individuals with sickle cell disease? Early diagnosis would improve survival. However, it takes some time before individuals are diagnosed. Newborn screening is not accessible to everyone in sub-Saharan Africa. We are still diagnosing people at the age of 55 with sickle cell disease for the first time. And so someone lives for 55 years and never knows that he or she has sickle cell disease. So individuals are diagnosed late, and therefore at that time they present with a lot of complications. In order to diagnose the condition, you would want to look at the blood. You do a full blood count. You look at the blood smear, which will show you sickle cells. You do your hemoglobin electrophoresis, and also you do your HPLC, which will quantify the hemoglobins for you, which is much more preferable. Now, genetic tests for genetic mutations are available, and therefore we can even do fetal testing as early as 8 to 10 weeks of pregnancy. So in managing sickle cell disease, your goals are to prevent hospitalization, reduce the symptoms and manifestations of the disease. You want to prevent and manage complications. You want to prevent organ damage and prolong life, and you want to improve the quality of life of the individual. If you look at the pathophysiology of sickle cell disease and the fact that it affects almost every organ of the body, it will tell you that the management of individual with sickle cell disease is multidisciplinary. Almost every specialty would manage an individual with sickle cell disease for a particular type of complication. So the hematologist and the primary care provider may be the primary care physician for that individual, but it's important that all other members of the healthcare team are integrated and involved in the management of individuals with sickle cell disease. Um, Early public health interventions that we can do. Number one is we mentioned newborn screening. It should be made accessible for everyone. And when an individual is diagnosed as early at that age, you put in prevention of infection through the vaccination. So you put that individual on the vaccination schedule. You educate on prompt treatment of infections. All right. You reserve blood for transfusion for cases of life-threatening anemia, especially if you know the individual has sickle cell disease. Most of the time, what happens is that when a person is not known to have sickle cell disease and presents with, say, an HB of 8 at the facility, we might end up transfusing that person a lot of blood, units of blood, before now the diagnosis of sickle cell disease is made. But if it is known quite early, then you would know, you want to find out what the stable HB of that individual is before you transfuse. And then adequate pain control and hydration of vaso-occlusive pain events, instituting hydroxyurea for management of vaso-occlusive complications, education on detecting splenic sequestration, and when to seek care from a healthcare provider. Usually from newborn screening, when the child is diagnosed, the parents are educated. And one of the things that they are taught to do is to be able to palpate the spleen, all right, especially when they notice that the abdomen is distended. The parents are actually taught to do that so that when they're able to detect it, they present the child quickly to the hospital. And then the parents are also educated that in terms of fever and other signs, they should present the child to the hospital. And then also we monitor for chronic complications and close monitoring during pregnancy. So you can see that from all that we've stated, newborn screening is what begins it. And therefore, if we get newborn screening to be accessible to everyone, once right from birth, we're able to diagnose that this child has sickle cell disease, we'll be able to institute preventive measures, make sure the child is vaccinated, make sure the child gets antibiotic prophylaxis right from childhood before any complications arise from these. Now, screening for associated conditions, the three I want to highlight is, I probably have mentioned them in passing, but renal disease. So at the age of 10, without screening individuals for proteinuria, you can use your usual urine strips to do that, or you can have special microalbumin urea strips to do that. You can actually do a urine albumin creatinine ratio uh, at a lab. We can screen for strokes using the transcranial Doppler, like I mentioned, from up to the age of 18 years. Above that, you can use MRIs or CT scans to do that. Retinopathy, from the age of 10 years, every individual should have the eyes screened by the ophthalmologist. So infection prevention I already mentioned this. You make sure the child is, I guess, all the routine immunizations. And now we have immunizations against Streptococcus pneumoniae and Haemophilus influenzae as part of standard care. And you make sure the child gets oral penicillin prophylaxis. And also, strategies put in place for malaria control. Yes, individuals with sickle cell disease can get malaria. And when they get malaria, it can be quite severe. Already they have low HPs. So the current management options, I'll be rounding up soon. These are lifestyle and non-pharmacologic options. I've already gone through this. But what I want to highlight here is the cognitive behavioral therapy, which can be helpful in developing coping strategies for the individual. And also what I haven't touched on yet is depression screening, what is recommended for adolescents and adult patients. So these are the pharmacological therapies that are available. At the center of this is hydroxyurea. We have gene therapy, which is available. Of course, your analgesia, opioids and non-opioids. L-glutamine, yes, an amino acid formulation that is also available. Of course, we mentioned blood transfusion. Crizanlizumab, which is a p-selectin inhibitor, is approved for use in the United States. So we have patients who are on it. There was a system trial which showed that there was significant reduction in acute painful episodes in individuals with sickle cell disease. Voxzogo was available, but it has been withdrawn by the manufacturer on account of some issues. So that has been withdrawn by the manufacturer himself. And then you can have stem cell transplant. So hydroxyurea is what I wanted to talk about. It is indicated for the prevention of recurrent vaso-occlusive painful episodes in adults, adolescents, and children from over 2 years. Even with some guidelines, because of the studies which have been done in babies, you can actually start hydroxyurea therapy as early as 9 months of age. So it is recommended to reduce sickle cell related complications in pediatric and adult patients. It comes in capsules or tablets. The dosing is 50 milligrams per kg per day for adults and 20 milligrams per kg per day for children. So because it causes myelosuppression, you want to monitor. The maximum dose that you can give to an individual is 35 milligrams per kg per day. All right. And you want to monitor for toxicity. So you'll be monitoring the neutrophil counts, your platelet counts, your hemoglobin, and then your reticulocyte counts. And when there are any toxicities below the levels that are specified, you either reduce your dose or withhold the medication for the counts to recover.
Dr. Gani, we
So
have
yes,
three more
hydroxyurea is
minutes.
safe.
3 more
3
minutes.
more
3
minutes.
more minutes, please. Yes, the second speaker
Yes.
is waiting. Thank you.
Yes, please. Thank you. So it's safe, causes myelosuppression, like I mentioned. So you would have the anemia, low platelets. There could be other hypersensitivity reactions to it. With regards to contraindications, when a person has very severe hepatic or renal impairment, or when the person has hypersensitivity to it. But even in situations of mild or renal liver, mild to moderate renal or liver impairment, you can actually use it in the individuals. So I think I can skip this slide. So the last thing is blood transfusion. In Africa, is not readily accessible. The complication that comes with that is iron overload, and usually becomes a challenge, especially iron chelation 2 becomes and is not very accessible to a lot of people. And even if it is, the cost of iron chelation therapy is very high. So at my last point was the mental health in sickle cell disease. People living with sickle cell disease face challenges to cognition, psychological disorders, and overall decreased quality of life. So they can have depression, anxiety, feelings of failure, post-traumatic stress disorder due to their disease and its complications. Okay, it affects their relations, education, and then it affects their employment too as well. They can have sleep disorders. So it is important that we screen for depression and anxiety in our patients. It is reported that as much as 39% and 38% of people live with depression and anxiety, respectively, in sickle cell disease. So there are simple tools that you can use to screen for depression and anxiety, and it's recommended that we do that. And depending on the grading, whether mild, moderate, or severe, you refer the individual to see a psychologist. So addressing depression and anxiety can help improve medical outcomes as patients are more likely to stick to treatment schedules, exercise, socialize, and maintain a healthy diet. Even if a patient is feeling mentally well, counseling or therapy is still often helpful. All right, so I'm done. I was going to the summary so we can have a second speaker. Thank you very much.
Thank you very much, Dr. Gani, for your presentation. And I'm glad you shared your thoughts on the new trends and the new management of sickle cell disease. So if anybody has questions, they should drop it in the chat box. When the second speaker is done, then we'll tend to the questions. At this moment, I would like to introduce our second speaker. Sorry, please let me share my slides. One minute, please. Okay. All right, I don't know why my slides are not moving. Okay. Sorry, please, I'm having technical issues as well. My slides are not moving.
Angela, why don't you speak
Can I-
to it
Can I?
if nobody's
Okay.
citation?
Because I need to share her slides as well. Okay, so good evening, everyone. Sorry for that. I'm introducing Dr. Bolanle Okunowo. She's a seasoned physician and a consultant endocrinologist who is currently serving at Lagos State University Teaching Hospital, Ikeja. She's the lead consultant of the hospital's Diabetic Center of Excellence, where she focuses on improving access to diabetic care, particularly among women and vulnerable populations. Her role also involves teaching medical students and training junior doctors in clinical endocrinology and internal medicine. Over the course of her career, she's worked in both public and private health institutions, including Chevron Hospital and several other private medical centers across Lagos as a visiting consultant endocrinologist. Her experience spans the management of endocrine disorders, general internal medicine, public health education, and she's appeared in multiple media engagements to discuss diabetes, thyroid disorders, and antibiotic awareness. She holds a bachelor's of medicine and surgery, and she's a fellow of the prestigious West African College of Physicians and the National Postgraduate Medical College of Nigeria. She's a member of the West African College of Physicians. In addition to her qualification, she's completed numerous local and international professional training programs in clinical endocrinology, research methodology, cardiovascular health, and leadership in healthcare. Ladies and gentlemen on the call, I would like to introduce her again and welcome her for a very robust presentation. Over to you, Dr. Okunowo.
Thank you so much, Dr. Angela, for the kind introduction. I appreciate Novotix for this invitation to speak on management of diabetes eye disease. Thank you.
Okay.
Okay, thank you. We can move.
Okay.
So now this is just my disclaimer. Kindly note that the views and the opinion of the speaker do not necessarily reflect those of Novartis, and Novartis recommend the use of their products only in strict accordance with locally approved packaging. So now, in terms of the learning objective, we'll be discussing the pathophysiology of diabetes. We'll look at ocular complication in diabetes. We're going to look at the management strategies. We'll look at the standard of care, with emphasis also on verified study because of the influence on the guideline in Diabetes Association, American Diabetes Association. We'll review the screening guideline for diabetes eye disease, and we'll talk about the practical tips for patient education. So now, diabetes is on an alarming increase globally, and the International Diabetes Federation has projected the prevalence of diabetes in 2025 to be 589 million. And Africa is not left behind in this struggle in battling with the burden and the complications of diabetes. It's been projected that come 2050, there'll be exponential rise of 142% increase in diabetes incidence in Africa. And this is the largest globally and worldwide. Now, it's also been projected that 4 out of 5 people living with diabetes in Africa, they are not diagnosed. And Nigeria, being the giant of Africa, is not left behind. In Africa, Nigeria is the leading prevalence of diabetes, accounting for 3 million population in Nigeria. And this has been projected to increase to 6.6 million in 2050. So we really have a huge burden in our hands to manage as physicians and specialists. Yeah, you can move. So now in Nigeria, because in Nigeria, the prevalence of diabetes is higher in South-South, accounting for 9.8%, and the lowest is in Northwest, which is 3.3%. So now, you can move, please. Thank you. So now, the issue with diabetes is because of the comorbidities and the complications it carries, because of the microvascular complication and microvascular complication. In fact, the microvascular complication I see in my clinic is accounting for almost 75%. And you see a lot of this patient presenting with both microvascular complication and macrovascular complication, almost 20 to 30% at first clinic visit. So this is a huge issue in our hands. Next one. So now there is a World Health Organization classification of diabetes in 2019, which is the current one. So we have the type 1 diabetes, which is strictly autoimmune, type 2 diabetes, which is multifactorial and polygenic in nature, and it accounts for 90% incidence of diabetes. There is a hybrid form of diabetes, other specific types of diabetes, unclassified diabetes, and hyperglycemia first detected in pregnancy. Next one. So now the changes are those where there are scars. The hybrid form was newly introduced, the unclassified was newly introduced, and the diabetes mellitus in pregnancy newly introduced. Next slide. Next slide. So now there are various risk factors for diabetes. It can be modifiable and non-modifiable. The modifiable ones, the high risks are the obesity, sedentary lifestyle, and diet. So those are the strongest modifiable. Then the non-modifiable, family history of diabetes, genetic factors, those are the really non-modifiable factors. So now, what are the criteria for diagnosis? A fasting blood sugar of more than 126 or a random blood sugar of 200 milligrams per DL. On 2 occasions, if the patient is asymptomatic, diagnosis diabetes, or HbA1c of greater or equals to 6.5%. Also, if a patient presents with the classical symptoms of diabetes, such as polyuria, polydipsia, polyphagia, weight loss, plus a random blood sugar of greater than or equals to 200, you can actually make a diagnosis at an instant. Next one. So now the pathophysiology of diabetes, like I said, type 2 accounts for 90% and type 1 is about 10%. Type 1 is strictly autoimmune due to autoimmune destruction of the islet cell of the pancreas in charge of insulin secretion. So when there's destruction of those islet cells, there is type 1 DM, but in type 2 is multifactorial. So the main platform for type 2 DM is insulin resistant, and this is due to genetic factors, aging, obesity, sedentary lifestyle, and so this results in insulin resistance. The insulin resistance now causes hyperinsulinemia as a form of beta cell compensation to improve glycemic control. So because of the insulin resistance, there is increased gluconeogenesis from the liver, causing increased glucose output, increased lipolysis, increased fatty acid. As a result, this further worsens the insulin resistance, and over time, the beta cell compensation of hyperinsulinemia is lost, and there will be now decreased insulin secretion. So the patient starts manifesting as impaired glucose tolerance and eventually develop overt diabetes mellitus. Next slide. So the management of diabetes mellitus is very important. It includes both lifestyle and medication. Talking about the lifestyle, you want to do medical and nutritional therapy. You want to do exercise this patient, talk about lifestyle modification. For medication, we have two broad classification of insulin therapy and oral anti-diabetic agents. Next slide. So now looking at the guideline, the American Diabetes Association 2024 guideline, it talks about still the bedrock for management of diabetes remain lifestyle. It can never be overemphasized. Diabetes self-management education, and for any diabetes patient, you need to do the cardiovascular risk factor for this patient. Does this patient have atherosclerotic cardiovascular disease? Does the patient has heart failure, chronic kidney disease? And you need to stratify your patient. So if this patient is a high-risk patient with cardiorenal, high-risk cardiorenal problems, then you want to initiate medication in order to reduce the comorbidities and progression of this disease. So you want to introduce a glucagon-like peptide, glucagon-like peptide 1 agonist, or you want to do a sodium glucose transporter 2 inhibitor. So this has been shown clinically, evidence, cardiovascular outcome trial to show both cardiovascular and renovascular protection. So now, considering the glycemic management of this patient, the guideline recommends clearly that there is benefit in initiating a person that is newly diagnosed with diabetes with a combination therapy. So it's advocating for metformin plus any other agent with a different pharmacological therapy, that this gives a better durability and improved glycemic efficacy of patients with type 2 DM. So if weight is the issue, you want to reduce weight, or you are interested in weight management because this patient is obese, then you want to introduce some drugs like semaglutide, dulaglutide, and the rest. Next one. So now this takes me to the VERIFY study, because it's the first randomized control trial on combination therapy of two complementary mechanisms of oral hypoglycemic agents in type 2 DM. And this study shows the durability of glycemic control when you start a combination therapy. And I feel that this also was part of why this guideline was adjusted to include consideration of combination therapy at diagnosis. So in this study, it was a two-arm study. Next slide. Two-arm study. There was a arm of metformin bedagliptin combination ab initio, and there was an arm of metformin placebo ab initio. These people were followed up. These two arms were followed up for 5 years, and they visit the hospital every 3 months in the course of this issue. And in the first, there's a period 1, period 2, period 3, talking about treatment failure, and the first treatment failure and the second treatment failure. So now, for people in the monotherapy arm, when there's a first treatment failure, a second molecule was added, which is a bedagliptin. And for both arms, metformin bedagliptin initiation at the onset and the monotherapy initiation at the onset with when there's a failure and they move to bedagliptin. If there's a failure, they move finally to insulin therapy. Next slide, please. So now the criteria used for this study was people people that had early diagnosis of type 2 DM. Those are people less than 24 months. Those people that were drug naive or maximum dose of metformin 4 weeks, and the age consideration were 18 to 70 years with good eGFR. Next one, please. So now, Okay, so now this study was carried out in, okay, so now let's go to the next one, please. Next slide. So now there's a significant reduction in the risk to time to initiation failure by 49% with early combination therapy versus the initial monotherapy. The initial monotherapy arm had a treatment failure, the first treatment failure at 36.1 months, but the second arm, there was no treatment failure. Even after the end of the study, it exceeded the duration of the study of 60 months. So talking about the importance of early combination therapy. Next one. So with the second treatment therapy, in terms of people that were on monotherapy and there was a treatment failure and they had to have the second molecule, there was, now comparing with those that initiated vidagliptin for me at the onset, there was still a significant 26% reduction when you compare the early combination therapy compared to the monotherapy. Next one, please. So what are the strengths of this very first study? You know, it's a first study, like I said, a long-term clinical benefits of combination therapy in newly diagnosed DM. And these have shown long duration and beneficial effects of combination therapy. And in this study, this was well tolerated and there was no untold side effects. Next slide. Okay, so the importance of this is because the United Kingdom prospective diabetes study have shown that with 1% reduction in HbA1c, the patient has a lot to benefit from. There's 21 reduction in death, 37 reduction in microvascular complication, 14% reduction in heart attack, 43% reduction in amputation and peripheral vascular disease, and also 12% reduction in stroke. So you really want to start right and eat it right because of the beneficial effect with reduction in HbA1c and the metabolic memory. The UK PDS have shown that with metabolic memory, when you get your patient right in the first instance, subsequent ones, the patient maintains and the rate of patient developing complication is minimized compared to people that never got it right in the first instance. So now we really want to prevent this complication, microvascular and macrovascular complication. The macrovascular complication starts from the brain. The patient can present with transient ischemic attack, cognitive impairment, stroke. For the heart, they can present with coronary artery disease, heart failure. For the extremities, they can have peripheral arterial disease, and this has led to a lot of amputation. In fact, diabetes is the leading cause of amputation in Africa and Nigeria and even globally. So now talking about neuropathy. Neuropathy is one of the microvascular complications of diabetes. They present with diabetes neuropathy. The kidney is not left behind. They can have diabetes kidney disease. And most importantly, the eyes. They can present with glaucoma, cataracts, and retinopathy. Next slide, please. So I'll be talking about the common ocular complication of diabetes. This involves retinopathy, and we'll be looking at it. Diabetes is the leading cause of retinopathy and the leading cause of blindness from retinopathy in Africa, in Nigeria, and even globally. So we'll also look at diabetes, macular edema, cataract, and glaucoma. Next one. So now this is the normal eye. So when you look at the normal eye, there's the anterior chamber and the posterior chamber, and there's the posterior part of the eye. The anterior chamber is what demarcates the anterior and posterior chamber is the iris. So from the cornea to the iris is the anterior chamber, and behind the iris, which is the lens, that's the posterior chamber. But we have the posterior part of the eye, which contains very, very important structures, talking about the retina, the macula, that's the fundus. It contains the fovea centralis, the macula, which the fovea centralis is a spot on the macula responsible for sharp and central vision. It contains the retina, it contains the optic disc, that's the posterior part of the eye. So when there's affectation of the lens, the patient can develop cataract and there can be also glaucoma. Next one. So now, diabetes macular edema, talking about affectation of the posterior part of the eye. This is due to fluid accumulation in the macula. This is due to mainly complication of diabetes and is one of the leading cause of central vision loss. The macula especially the fovea centralis, is responsible for central vision. So when there is affectation of the macula, there's loss of central vision. The patient cannot see along the central vision and can only see peripherally. So as a result, this is due to ischemic changes from osmotic effect of hyperglycemia, ischemic changes, and there's leakage, swelling, and finally blindness if not managed on time. So this patient is diagnosed using the optical coherence tomographic scan, and the treatment includes the use of antivascular endothelial growth factor injections, and there can be laser therapy to manage this condition. Next one. So cataract is not left behind. We see a lot of our patients presenting with early cataract because they have diabetes. The cataract is when there's involvement of the lens because of the osmotic changes. You see patients coming to the ophthalmology clinic and they want to do change of glasses, and they are advised that if their glycemic control is not good, you don't better do it, because by the time they give you a spectacle, by the time you come the next time, you will have to change it when your glycemic control, because there's lens edema, there's osmotic changes, and over time there's damage to this lens. The transparent lens become opaque and there's cataract formation. So they present classically with cloudy vision. They have poor night vision, and this is usually managed with cataract extraction surgery when the cataract is matured enough. Next one. They can also present with glaucoma. Glaucoma is also one of the major and feared complications of diabetes. This occurs when there is raised intraocular pressure, and this can also be due to the ischemic changes from diabetes, hyperglycemic effect, oxidative changes, and this eventually can cause irreversible damage to the optic nerve. So this patient presents with peripheral loss of vision, unlike a macula that is central. In glaucoma, is peripheral loss of vision, and so they have what we call a tunnel vision. So this patient bumps into objects. So diagnosis is using thermometry. You want to measure the pressure. You want to do their visual field, because by the time you do their visual field, you realize that they can't pick objects in the peripheral vision and they can only pick in the central vision. So there are different medications for management. The prostaglandin analogs, the beta blockers, Stimulol, the prostaglandin analog, lanatroprost, even the carbonic anhydrase inhibitors can be used for this patient, depending on the profiling of your patient. So also laser therapy can be used for this patient, and even trabeculectomy can be done for this patient. Next slide. DM retinopathy is another very feared complication of diabetic diabetes, which is one of the leading cause of blindness also in people with diabetes. This involves changes within the retina in a patient with diabetes. So, and is the leading cause of blindness in Nigeria and westernized country. Next one. So what are the risk factors? The duration of diabetes. For a patient with type 1, we want to screen from 5 years post-diagnosis. For a type 2, you must screen from the first day you are seeing the patient at diagnosis. It's been found that females have more incidence of diabetes retinopathy compared to males, and sometimes it can be hereditary. It runs in family. Pregnancy can exacerbate a pre-existing diabetes retinopathy that was undiagnosed. Hypertension also can worsen a pre-existing diabetes retinopathy not diagnosed, not managed. Smoking is a risk factor for worsening and commencement of diabetes retinopathy, obesity, and hyperlipidemia. Next one. So now what? The pathogenesis involve chronic hyperglycemia. You really don't want a chronic hyperglycemia. You really want to nib it on the bud, because this results to non-enzymatic glycation. There's oxidative stress. There's activation of the aldose reductase pathway, causing sorbitol, resulting in intracellular sorbitol, which has a lot of osmotic effect on the body tissues, especially the eyes. So as a result, there's damage to the retinal capillary, there's microangiopathy. This causes plasma leakage, macular edema, capillary occlusion, and eventually there's new blood vessels formation around the fovea, causing bleeding, and eventually there's a scar formation. This scar formation can now track on the retina and cause an irreversible blindness. Next one. So what are the clinical manifestations that such patient presents with? They present with worsening vision. they present with floaters and blurry vision. They'll say that they just notice their vision is blurred and their vision is really worsening. Next one. So now the classification of diabetes retinopathy can be non-proliferative. Under non-proliferative, we have mild, moderate, and severe. Then proliferative diabetes retinopathy, diabetes maculopathy, and advanced diabetes eye disease. Next one. So this is a normal fundus. You can see the vessels very good. In non-proliferative retinopathy, a lot of changes can, next slide, thank you, next slide. A lot of changes can happen, such as microaneurysm. There can be ad exudates. There can be venous abnormalities, bleeding, looping, and dilatation. Next slide. So this is showing the ad exudates, and there's retinal hemorrhages. You can see the ad exudates. You can see the hemorrhages. Next one. So there's venous looping. So within the veins, there's outpouching of the retinal veins because of ischemic changes around those veins. So over time, there can be bleeding of the vein. In the bleeding, there is constriction, localized swelling and constriction within the retinal vein. This is due to because of poor perfusion within the vein. So there's outpouching and constriction. And eventually there can be sedimentation of this vein. And over time, there can be total obliteration. Next one. So for the proliferative, there is new vessel formation, new vascularization. These vessels are very fragile and they bleed easily and they leak. They can cause a lot of edema in the macula and within the. So as a result, you can see these angry looking new vessels around the fovea. So this is it, and they bleed so easily. Next one. Okay, this is just comparing non-proliferative and proliferative like I've explained. Next one. So advanced diabetes eye disease, when diabetes retinopathy, maculopathy is not managed, the patient moves to advanced diabetes eye disease. In this setting, there is persistent vitreous hemorrhage, there's traction with continuous traction on the retinal till, there's absolute retinal detachment, and there can be neovascularization of glaucoma, neovascular glaucoma. Next one. So you can see the scar tissue, the ring of scar tissue, which can pull on the retina and detach it completely. Yes, so this continuous hemorrhage is persistent and nothing has been done about it. And this can lead to irreversible blindness. Next one. So this is talking about the neovascularization, neovascular glaucoma, you know, and so these vessels bleed easily. These vessels bleed easily and worsen the raised intracranial pressure, and they can be final optic nerve damage. Next one. So this is just comparing a healthy eye compared to a diabetic retinopathy here. You can see all the changes: dot and blot hemorrhage, retinal neovascular exudates, microaneurysm, continuous spots, the intraretinal microvascular abnormalities. So these are all the changes that happen in a patient with diabetes if not properly managed. Next one. So management is so important, and it starts from a good glycemic control. This cannot be overemphasized. So it's so important we monitor our patients. They come to clinic regularly. We monitor, they come with their self-monitoring of blood sugar chart. We monitor the HbA1c every 3 months. If controlled, then you can move to 6 monthly. But if not controlled, it must be every 3 months. And there should be regular adjustment of medication. And a patient should not be left on monotherapy for so long before you have the second therapy. Looking at the verified study. So initiation of combination therapy ab initio can help maintain adequate glycemic control, HbA1c control, and prevent diabetes retinopathy. So when the diabetes is controlled, depending on the stage of diabetes retinopathy and the retinopathy, you want to do laser photo coagulation therapy, which is a form of surgery using the laser therapy, and this helps to handle the abnormal vessel, the leaking vessels, the abnormal neovascularization vessels, in order to prevent blindness. There can also be intravitreal injection of antivascular endothelial factor. This molecule is very important because it prevents neovascularization. It prevents growth, formation of duplication of these vessels and formation of these fragile vessels that can worsen the vision and cause eventual blindness. Next one. Next one, please. Okay, so this is this is a man that is being injected with anti-veg into the vitreous chamber. Next one. So now there are different molecules that are being considered. There is the beta blocker. We're talking about propranolol. This is used in prematurity maturity in children, especially premature retinopathy. We have the steroid implant. The steroid implant can be used into the vitreous area, and this steroid can be triamcinolone, dexamethasone, and they are released in quantum. And what is their function? They help prevent inflammatory effect, abate it. They help with the swelling, leakages, causing diabetes macular edema that worsens central vision. So with the steroid implant is really beneficial for the patient. So for some is already in use. So we also have the methotrexate. The methotrexate can be injected into the vitreous chamber if the anti-VEG fails. The methotrexate has anti-proliferative effect, it has anti-inflammatory effect, and as a result, it prevents multiplication and proliferative retinopathy that leads to eventually advanced diabetes eye disease that tracks on the retina and cause blindness. Also, fenofibrate has been shown to be useful. As we all know, fenofibrate is an anti-lipid drug and is used for maintaining control of cholesterol and triglyceride. This fenofibrate has been shown to have anti-proliferative effect, anti-inflammatory effect, and it's been found out that with fenofibrate there can be slow progression of diabetes retinopathy. There's also the kallikrein drugs. Like those kallikrein drugs are still new molecule drugs, and the essence is to prevent diabetes macular effect, the progression, reduce inflammation, and reduce progression of diabetes retinopathy. Next one, please. So now talking about the eye and diabetes novelties, we have the insulin eye drop. The insulin eye drop has been useful it has some anti-inflammatory effects, and it helps to prevent inflammation around the eyes for the insulin eye drop. So it has this anti-inflammatory effect. So those are the novelties in diabetes care. So there's also the blood glucose contact lens. It's put in the eyes, but it helps to monitor the blood glucose of the patient. If it's high, it changes the color, it changes color, and the patient can actually know, oh, my sugar is running high. So it's like a smart contact lens. There's also another sensor, which is the conjunctival glucose sensor. This helps to sense the glucose in the tears. And this glucose, if it is high, it's especially for people that want vision correction with lenses and everything. So when their glucose is high, you will know that there can be lens edema, and you really don't want to give the vision, the glasses. Or next slide. Sorry, I think she has. Hello. Hello. Hello.
Hi, Doctor. No, I think
Yes.
Dr. Angela has some challenges.
Oh, okay.
I'll try and project from this end.
Okay.
Let me just try and get.
Okay.
Can you see my screen now?
Yes. Next slide. Thank you. Next slide. Next slide again. So now diabetes retinopathy screening. So it's important that programs that use retinal photography. In fact, the smartphone can actually take a fundus photograph and it can be sent anywhere in the world for interpretation. So using especially those with 20D condescending lens, they can actually take a fundus photograph. So the use of retinal photography and also the artificial intelligence algorithm can be used for screening for patients for retinopathy. Also, people with pre-existing type 1 DM or type 2 DM that are planning pregnancy should be screened for retinopathy, because by the time they get pregnant, there is worsening of the retinopathy if there's a pre-existing undiagnosed retinopathy. So it's important that they are counseled even at the prenatal clinic ahead of pregnancy. Also, those that are pregnant that have with type 1 DM, they should have a regular every trimester screening of their eyes, and even 1 year postpartum, depending on the degree of retinopathy they had prior to pregnancy. Next slide. Next slide, please. So now, the preventive measures include regular eye examination. It's important all diabetes patients, especially type 2, must have annual dilated eye examination. It's not about, oh, my eyes was not dilated, they just checked it must be dilated, to look clearly at the fundus, the posterior aspect of the eye. So the eye examination is not complete until a dilated fundoscopy. So blood sugar must be controlled appropriately, optimally, and blood pressure, cholesterol management is important, and lifestyle modification can never be overemphasized. Diet, exercise, smoking cessation, weight loss is quite important. Next one. So this is just talking about a comprehensive examination. There must be a dilated fundoscopy. Next one. So patient needs to be educated on the risks of diabetes and eye disease, the management strategy. Any patient presenting with type 2 DM in the clinic must be referred to the ophthalmology or optometrics for eye examination. There should be the support group can be useful in order to ensure compliance and ensure with support group support group have been beneficial in managing non-communicable disease. And next one. In conclusion, diabetes is the leading cause of retinopathy and is the leading cause of metabolic cause of irreversible blindness. Is totally prevented. So once there's prompt diagnosis of DM and optimal management and prompt referral to the ophthalmologist or optometrist at the time of diagnosis, a lot of things can be averted and blindness can be reversed. And for type 1 DM, 5 years after diagnosis, or when they complain of any visual problem, we must refer them to see the ophthalmologist. Next slide. These are my references. Thank you very much.
Thank you very much, Dr. Okuno, for this brilliant session that we just had. I think we need to appreciate Dr. Okuno for that succinct and brilliant session. Thank you very much. Also, again, to thank Dr. Gani for his first session also. I think we've had a lot to learn today, both from the first session on sickle cell disease and this second session on diabetes and its ocular complication. A big thanks once again to our very experienced speaker. So now, the time we are waiting for is here. Please, let's all mute our mic if you are not speaking. So now we are in the session of question and answer. We've been asking if you have questions, you could have dropped it, or you can still drop it in the chat box. Or if you want to speak, you can signify by raising up your virtual hand, would allow you to speak. So now it is time for us to ask our burning questions, queries, or if you want speakers to share their experiences with any of us. So now is the time. So the floor is open to all our doctors now for questions and queries to any of the speakers this evening. Thank you. Questions? Who wants to break the ice in terms of asking questions? I'm trying to see the chat. I don't think there's any question yet on the chat box. Questions. I'm sure we can all hear me. So if you have questions, this is the time for us to ask our questions. If there are areas we need clarification, or you want either Dr. Gani or Dr. Okunowo to share their experience, this is the time for us to do that. I don't want to believe there is no question from all our doctors on the call. Questions. Okay, while we wait for questions from our colleagues on the call, I'd like to ask Dr. Gani this question.
Hello, Femi.
Yes, Angela.
Okay, I wanted to break the ice, but
okay, yes, I know you are back. Okay, so you can break the ice here.
Okay, so maybe my question will be to Dr. Okunowo. Thank you for that powerful presentation. So, you know, with the way you've talked about diabetic retinopathy and with the silent nature of it, and also having limited retinal specialists in Nigeria, you know, what exactly is scalable for what will be like a frontline solution to implement so that this disease can be reversed early or can be managed early, like when they come to the hospital. What do you think, as an endocrinologist and being also in a public setting, how do you think these patients will benefit from early management, and what do you think can be done to help them to also prevent this irreversible blindness? So that would be my question for Dr. Okunowo. Then for Dr. Gani, I hope I got it right. Thank you for your presentation as well. Quite educative. I'm so sorry that I didn't let you finish up, but I was already feeling like a sickle cell specialist from the few slides you shared. So my question will be, you know, you mentioned about Africa having over 75% of global sickle cell births. Then most patients also have this lack of access to early diagnosis, hydroxyurea, and even comprehensive care. How can we shift from episodic crisis? Why do we have to wait for patients to have episodic crisis? How can we shift from that to having a structured, you know, like a preventive model where the patients have this care? Because I've really experienced patients that have sickle cell, and most of them is when they have this episode. So how do we prevent it? Even from like the primary care center, what do we do without us over relying on donor-driven intervention? So that would be my question for you. So thank you for the speakers, and over to you, Femi.
Yeah, thanks a lot, Angela. Before our speakers start answering the question, I just want to also inform our colleagues on the call, doctors on the call, that while we are getting answers to the questions, please, we'll be dropping some forms on the chat box. The first one will be the feedback form for today. Please kindly help us give us feedback about how you perceive today's meeting. And then we'll also be dropping the CME form on the chat box. That's mainly for our doctors in Nigeria, because I know our doctors in Ghana, they have their own CES will be handling that. For doctors in Nigeria, if you need to also fill the CME form so that we can send your CME points to you after this meeting. So those are the two announcements I have for us. Thank you. So over to who is going first now? Dr. Okunowo. Thank you.
Thank you so much, Dr. Angela, for that question, because I work in the public setting, so this is a huge one. As Nigerians, there's a lot of poor health-seeking behavior in Nigeria. People hardly come. I see a lot of cases like that, you know, both educated and non-educated, you know. I remember seeing a patient, and he was noticed to have blood sugar instead of presenting to the clinic, went to a store, bought one drug. By the time he developed erectile dysfunction, he now came to the clinic. By the time he now came to the clinic, he has diabetes peripheral neuropathy, he has diabetes high disease, but he was in the severe non-proliferative diabetes high disease. He had bleeding and segmentation. So there's a lot of issues to do. And I feel this form of education cannot be overemphasized. People need to be educated on diabetes. They need to be educated on the complication of diabetes. A lot of times the eye complication has been thrown to the back. And most times people are aware of developing ulcer, people are aware of kidney issue, but hardly do people talk about diabetes eye disease. So I feel there should be more education. That's why most times when they present to the clinic, we educate them and we tell them to educate others. They should be an advocate to keep educating others around diabetes. So that's why when they come to our clinic, we want a one-stop shop. And I advocate that most diabetes centers should try and run a one-stop shop with the ophthalmologist. They are there in our clinic. As we are seeing, we are referring straight there, and then by the next door, we just refer. The patient goes there, whether you have eye complaint or not, because a lot of them could present asymptomatically till it's advanced. So we advocate for early screening, improve diabetes education, diabetes advocacy in education, prompt glycemic control. Prompt glycemic control. There should be clinical inertia should be stopped, and based on what the guideline is even advocating for, early combination therapy with patients with diabetes in order to prevent early treatment failure in people managing with. And you need to control all the other comorbidities. Hyperlipidemia, hypertension must be controlled. Hyperlipidemia, they must be screened. Most pregnant women in Nigeria that have DM, they hardly do a prenatal screening for diabetes retinopathy. They get pregnant and present with worsening of vision. So all this needs to be tackled, and it's really a lot to be done, but a step at a time we'll get there. I think those are my comments. Thanks very much.
Thank you very much for those very clear and on point answers to that question. You still have some questions, but we'll hold it for now. Let's hear from Dr. Gani. Dr. Gani, there are more questions there. Should I read them out so you answer them once, or you want to answer that first, the one Dr. Angela asked you? You still have more questions in the chat box.
Yeah, so I didn't hear Dr. Angela's first question. I had a second question, but not the very first one, so she can repeat that.
Okay, no, Dr. Gani, I was saying that listening from what you presented, okay, with Africa accounting for 75% of global sickle cell births, right? I know you mentioned about, patients lacking consistent access to early diagnosis, hydroxyurea, and comprehensive care. So my question is, what can we do to shift from episodic crisis management, maybe we're just waiting for when there's a crisis to manage them, to, to have a structured preventive care model? That was my question.
All right. Thank you. So I think that the first place I'll begin from is to have a very strong policy when it comes to managing sickle cell disease patients. We are in sub-Saharan Africa. We have a high burden of disease, but it will be surprising to know that when you go to the various ministries of health across board, there aren't any very strong policies when it comes to managing individuals living with sickle cell disease. You have maybe a country like UK where the sickle cell disease patients who are registered at my facility alone are more than the sickle cell disease patients in the whole of that country, but yet they have a national registry. They have a strong policy for universal access newborn screening. So I believe that where to begin from is to advocate, really push in terms of when it comes to governance for our ministries, various ministries across board to have very strong policies in handling individuals with sickle cell disease patients. Then educating the public and educating individuals living with sickle cell disease as well. Now, for instance, when it comes to hydroxyurea, even though hydroxyurea is available now, you still have a lot of patients who have sickle cell disease who, when you mention hydroxyurea, they are scared of the drug. All right, they read all sort of things on the internet, and when you come to the facility and you mention it to them, it's like they don't want to come near the medication at all. So if we can strengthen our education through all our stakeholders and all our support groups, it's going to help a lot. And then finally, within the facilities, we should have very strong protocols for managing individuals with sickle cell disease. So I think the first place to begin from to have governments buy in and have very strong policies for managing individuals or for the care of individuals living with sickle cell disease. Fortunately for Ghana here now, at least hydroxyurea is on the health insurance. So that is a bit accessible, even though sometimes there might be gaps in when patients can get the medication and all that. And it's not even accessible through all facilities, but at only some special centers. But I think that's a one step forward. So that's what I would say concerning that. I don't know if that addresses your question. I think that should.
Thank you, Dr. Gani. Before you go, I still have more questions for you. Let me just read them from the chat here. I think our participants are now bombarding our speakers with the questions. So the first question for you, Dr. Gani, is in the management of VOC, which is the appropriate intravenous fluid to administer? Thank you. So that's one.
All right, so
let me read the second one so that you take them together. Then the second one says, in a sickle cell disease patient, genotype SC or genotype AC, who rarely has crisis, should such a patient present with symptoms of non-specific abdomen? Should abdominal VOC be the first on the list of differentials, or that can be one of the many differentials? That's the second question. I hope that is clear. I was struggling to read that second question. Dr. Gani.
All right, thank you. Yes, thank you very much. So in the management of sickle cell disease patients, when it comes to fluid therapy, what we've seen over the period and what has been documented in literature is that the ideal fluid to use is to go for dextrosaline or to go for Ringer's lactate instead of normal saline. Normal saline has seen over the period not really improve the care when it comes to managing individuals with sickle cell disease because of the tonicity. Usually the sickle red cells themselves are dehydrated. If we looked at the pathophysiology of sickle cell disease, there's damage to the membrane, there's damage to the iron transporters on the membranes, and therefore there's leakage of water out of the cells. That's how come we have dense cells in sickle cell disease. So the best fluids to, in a way, help with the management of sickle cell disease is to go in for dextrosaline or Ringer's lactate. But having said that, if a patient is obviously dehydrated, remember that hydration as part of the management of sickle cell disease patients who come in VOCs is not necessarily because the individuals are dehydrated, but the hydration helps with the management of the vaso-occlusive crisis. But in a situation where the individual is dehydrated clinically, then in terms of correcting the hydration status of the individual, you can use normal saline to do that. Once that is corrected, you switch back to your DNS or your Ringer's lactate. So that is what is recommended. Now, when it comes to somebody who has SC and rarely has crisis and comes with abdominal pain, yes, you are going to think of other things, but abdominal VOC too should be part of the differential. So you're not going to stick to abdominal VOC alone, but you're going to look for other causes of abdominal pain as well. Even in someone who has sickle cell disease, who is, say, hemoglobin SS, remember that even though the person has sickle cell disease, any other thing that can cause acute abdomen can cause acute abdomen in that individual. So that's why it's important that when a person comes in with pain, you really want to look at what's the precipitating factor of the pain. You want to take a very good history and want to examine the person very well so that you can get to the bottom of what really is the cause of the pain. So yes, abdominal VOC will be part of your differentials, but you should look out for other causes of acute abdomen too as well. There's something about genotype AC. I don't know what there's no question attached to it, but what I would say on genotype AC is that someone who is AC does not have sickle cell disease. All right, sickle cell disease is having hemoglobin S with another abnormal hemoglobin. So SSSC, S with any other abnormal hemoglobin. So someone who is AC does not have sickle cell disease. So that person should be fairly okay. But that's why when it comes to testing or screening, it's also very important that we don't stick to the sickling test. Someone who is AC can go and do a sickling test and it is negative. But if an AC individual marries someone who has AS, then it's possible that they can give birth to someone who is SC. So that's why even when it comes to screening, the minimum that we recommend is for you to do at least an HB electrophoresis. Better still, you can do an HPLC or isoelectric focusing, and you can get to quantification of your hemoglobins. Thank you.
Thank you very much, Dr. Gani, for those concise and succinct answers. I'm sure our doctors appreciate that, and we are learning a lot. So I think I'm going to the chat again. There are still some questions for Dr. Kuno. Okay, Dr. Kuno, this is for you. Thank you for the presentations. Please, is the use of statin mandatory in DM? Also, the controversy surrounding the use of rosuvastatin in diabetic patients. That's one. Then let me see, I think there's another one for you. Second one, still for Dr. Okno. Good evening, and thank you so much for the beautiful presentations. Please, what's the frequency for eye screening for diabetic patients without complications on follow-up? Over to you.
Okay, thank you so much, Dr. Femi. So I'll just quickly start from the rare and move it. So now, in terms of screening, so a patient with type 2 DM must be screened for diabetes, diabetes retinopathy or diabetes eye disease on the first day, as you are seeing. As you are seeing, we are giving a referral letter to see the ophthalmologist. And so when the patient gets to the ophthalmologist or optometrist, they do a fundoscopy, dilated fundoscopy. Once the fundus is fine, they tell the patient, depending on if it's completely fine for type 2, they will tell them come exactly a year after. They monitor serially for like a year continuously, 1-2 years continuously. If it's not fine, they can increase it to 2 years. But if they found any form of retinopathy, depending on what they find, whether proliferative or non-proliferative, will determine that they'll give them more frequent appointments than 1 year. So, but a patient planning pregnancy that is diabetes or type 1 or type 2 must come for fundoscopy, even if the type 1 DM was just diagnosed 6 months ago. As long as the patient is preparing to get pregnant, must be screened for retinopathy ahead of the pregnancy. And during pregnancy, the patient needs to be screened every trimester, till 1 year postpartum, depending on, or because a lot of changes can keep up going based on. I hope I did answer the question. Okay, so now talking about the second question on rosuvastatin. Statins generally is very mandatory for a patient with type 2 DM. I see a lot of cases of patients coming into clinic, type 2 diagnosed, years and not on statin. By the time I'm seeing them, a lot of complications has already developed. Why? Because number one, beyond the glycemic control that we said, avoid clinical inertia, there are other factors you must manage in a patient with diabetes. That's why all the guidelines, American Diabetes Association, European Association of Study of Diabetes, WHO, everybody is saying statins, statins, and statins. Why? The use of statins in a patient with diabetes is not just for the cholesterol. Statin has a lot of beneficial effects in a patient living with diabetes. It has a cardiovascular protection effect, endothelial effect. Most people with diabetes have endothelial dysfunction that makes them at risk of atherosclerotic cardiovascular disease and make them at risk of peripheral arterial disease. So a patient that is diagnosed with diabetes must be on the statins. So statins is recommended from 40 to 75 years of age. And even after 75, a patient can decide to go ahead of to continue the statin. You know, I remember a case that the person is about 76-year-old. He's been on statin. This daughter is a pharmacist. And when the man clocked 76, the doctor came to me and said, Dr. No, I want to reduce the pills of my dad. I think we should stop the statin. I told her, let's maintain even a maintenance dose of statin. She was like, no, she just wants to reduce the pills. And unknowingly to me, the statin was stopped. The patient presented with heart attack. There was a myocardial infarction within a month of stopping statin, because the work of statin goes beyond. The cholesterols were fine, but it does a lot of endothelial function for a person living with diabetes. So there's no drug that does not have its own side effects. So there are some recorded side effects of rhabdomyolysis, myopathy, and everything. They are not so common. And when you want to compare the beneficial effect of statins against not using it, it's far apart. That's why they call diabetes a cardiovascular equivalent. So it's a cardiovascular equivalent. So a patient with diabetes is a high-risk patient and should be on a statin. Yes, except type 1 that we don't classically give statins. So statins usually recommended between 40 to 75 years. I think I hope I did answer the question. Thank you.
Yes, ma, you did. Thank you very much, ma. We are running out of time. We have less than 5 minutes for this session as we round up. But there are still about 2 more questions for Dr. Okunowo, which I'll read the 2 so that you can also address them. I know more questions are coming up. But before I do that, I know there was a question around the CME points on the chat. Let me just clarify. For the CME points, we didn't share any form yesterday. We are sharing the form today, and the CME points covers for the 2 days. They're giving 4 CME points for attending yesterday and for today. So don't bother that you didn't fill any CME form yesterday. The CME form is just for today and to cover for yesterday and today. Thank you. So the next questions for you, Dr. Okunowo. Please kindly share some light regarding dietary counseling to diabetic patients on follow-up. That's one. And then there's another one. Let me quickly get there. I need clarification on this. For a type 2 diabetic that is not doing well on OHA, or hypoglycemic, can metformin be combined with insulin for such patients? Dr. Knoll, please, you have just 1 to 2 minutes.
Okay.
The last question
sorry, I can't remember the first question. Let me quickly answer the second question. So, metformin can be combined with insulin, you know, and a patient, ideally, the guideline 2024 is even initiating combination therapy. So you can actually start metformin with gliptin ab initio, you know, so that the treatment failure time is not shortened. Even if the patient will fail, it will be almost 5 to 6 years post initiation of therapy. So combination therapy. So after combination therapy, and maybe it fails, you can add insulin, like a basal insulin to initiate with the patient. And there is a way you calculate the insulin. You know, there are guidelines on how to calculate the insulin based on the HbA1c and the weight of the patient. Then you initiate the insulin. So insulin can be added to any medication. When you are adding it to sulfonylurea, just reduce the dose of sulfonylurea. But with metformin, you can add a vidagliptin ab initio, improve the glycemic control. If there's treatment failure, like in Verify study that shows 60 point something months, then you can now add an insulin, like a basal insulin. First question, I can't remember, sorry.
Yes, can you share some light regarding dietary counseling to diabetic patients on follow-up?
Yes, so it's important that when the patient comes, a diabetes patient is holistic. Like in our diabetes clinic, we run a dietitian runs it with us, where it's a one-stop shop. So they run the way. So for a patient with dietary management is very, very important because it's not all about. That's why all guidelines says dietary lifestyle management as a baseline. So now you need to talk to them about calorie count. You need to calculate the BMI of your patients. You need to know and calculate the caloric intake per day for your patients. So based on the BMI, you want a weight losing diet. So you calculate your total calorie per day. You now apportion it to protein, complex carbohydrate, vegetable, vitamins, and fiber. So now for the vegetable, according to the serving plate of diabetes, half of the plates must be vegetable. Then a quarter carbohydrate, the other one's protein, fat and oil, water, and with a lot of fiber. So you must pick a high fiber diet, a diet low in polyunsaturated fatty acid, and a lot of hydration for your patient. And you must set their glycemic targets. A patient must not be seen and you don't give them a glycemic target of fasting blood sugar, what it should be, 2 hours, what it should be, and HbA1c, what should be. Because this educates the patient and let the patient know, am I doing well or not? If the patient is not doing well, we present much earlier to you for further modification of therapy. So it's so important dietary management is instituted for diabetes management. So you want to avoid refined sugars, fuzzy drinks, and all this. So this patient needs to be properly educated on the diet, on food care, and so is a whole lot. And the more we start, the better we get a better outcome in terms of preventing the complications, both micro and microvascular complications of diabetes. Thank you very much.
Thank you very much, Dr. Okunowo. I know if we give you 1 hour more, you are so passionate about diabetes management. So our last question for today goes to Dr. Gani. Thank you for the presentation. How do we manage consistent sickle cell priapism without surgery? Dr. Gani, please, can you take it in a minute as we're out of time? How do we manage consistent sickle cell priapism without surgery?
All right, thank you very much. So the important thing to, first of all, is to educate your male patients that anytime they have such a condition, they report to the hospital, because the longer it persists, the risk of developing erectile dysfunction. Unfortunately, some patients develop priapism and they keep it to themselves until they can't do anything about it. But when they present with the facility, hydration and pain management key. Disease-modifying agents which have been shown to be effective against priapism. One is hydroxyurea. There are patients that were having persistent priapism. Once we started them on hydroxyurea, the priapism resolved. Another drug, crizanlizumab, which is a P-selectin inhibitor, is very effective when it comes to priapism. It may not be available in the environment. Our site happened to be fortunate to be part of the STAND trial, and all our male patients who were having priapism, who were on the medication, their priapism resolved and has been reported in the other countries which they use the drug. So those are disease-modifying therapies when it comes to sickle cell disease. The other drugs are not targeted to sickle cell, but the blood vessels themselves. So we give drugs like flutamide, and then pseudoephedrine, alpha-adrenergics, phenylephrine. All those can be given to manage priapism. But it's very important that you still, even though you want to manage medically, you still consult or refer the patient to the urologist so that they can have a second assessment of that individual, especially when it studies medications and it is not resolving. But from my experience, hydroxyurea, crizanlizumab, flutamide, when you give it to the individuals, and their priapism does resolve. So you can start with that, but if it persists, you have to still refer to the urologist. Thank you.
Thank you very much, Dr. Gani, for that response. I'm sure our doctors are well informed and we are living here upskilled. So as we round off, we have just 2 more minutes. I don't know. I can see we have on the call Head of Medical for Novartis West Africa, Dr. Jerome. Are you there? Can you hear me? Just give us a short closing remarks in the next 2 minutes if you are there. Thank you. Yeah. Jerome.
Thank you very Remy. And first and foremost, I want to warmly applaud our facilitators
starting from yesterday, Dr. Francis Agikum to Dr. Ramalan, and today we had Dr. Gani and Dr. Okunowo. I totally want to agree with what you all have said from yesterday to today. And today, I believe as we wrap up, this has not just been a masterclass, but it has been a forum where we have been able to exchange scientific ideas, and also this could also step change our practice. I want to thank everyone for coming to this year's annual GP class series that Sanofi Novartis continues to power. I want to say one thing. The journey does not stop here. Please reach out to our facilitators. I know the slides will be made available to everyone. And as we continue to improve patient outcomes, as we leave this room today, for the last 48 hours, it has been a time for us to reflect. Maybe in terms of diabetes and the eye, maybe in terms of the patients today that we see that have sickle cell, or maybe those patients that had dyslipidemia, and today we have been able to profile solutions to them. I want to thank you, and I know that we will continue to join hands to improve the practice and also improve patient outcomes. Thank you so much for joining us for this last 2 days, and we hope to connect with you very soon on the field. Thank you so much, and have a beautiful evening. Over to you.
Thank you very much. Thank you, everyone. Have a great evening. See you soon.
Femi.
Bye. Thanks, Jerome. Thanks, everyone.
Thank
Bye.
you.
Okay, bye.
Thank you. Thank you, everyone.
Bye.
Have a good evening. Thank
Bye,
you.
Yeah,
everyone.
bye.
Thank you.
Thank you.
Yeah.
Guys, the medical team, are you guys waiting behind, or you're
you.